for joining. It is Ask a Birth Professional day today. I'm here with Selia Busey. She's a CPM, that's a Certified Professional Midwife. We'll talk a little bit more about what that means. She's working on her state licenses currently. She's been in midwifery since 2005. That's when she started school. In 2007, she started training as an apprentice. She has two beautiful daughters, aged 5 and 7. Her husband is an Army physician. He's in family medicine, and she currently attends home births. She does attend water births and has experience with breech, and she's, trained for breech and twin births. So, with no further ado, Celia, why don't you tell us a little bit about why you decided to become a CPM and how that's different from other midwives?
I have been interested in birth for as long as I can remember. And in high school, I shadowed a certified nurse midwife, and I was not at all impressed with her job. She was very much it was very clinical. It was not at all what I envisioned midwifery to be. So I changed paths. I thought maybe I would go into ultrasound. I was working on the prerequisites to get into the ultrasound program. My counselor put me in a wrong science class, and so I would have to wait till the following year to be able to apply. And in the process of just following internet trails down the rabbit hole, I came across home birth midwifery. And I thought that is perfect. That is exactly what I want to be doing. And so I just completely changed courses and found a school and got started there.
Okay, so what is one of the biggest misconceptions you've encountered about home birth?
About home births or about home birth midwives?
Oh, either or.
Probably a lot of people are under the impression that we're just there to help catch the baby. Realistically, we go through a lot of training, and we do carry the same medications and equipment that are typically stocked in a hospital delivery room. The exact medications vary by state, depending on what they allow. But here within Texas and New Mexico, we typically carry Pitocin, Cytotec, Methergin, here's my 5-year-old, oxygen, resuscitation equipment, lidocaine, and suture material. So we carry a good amount of gear to make sure that we are prepared for a birth.
So you don't just deliver babies in barns and things like that?
We don't. And we also do carry Dopplers to monitor the baby during the labor. It's actually what is recommended currently. Continuous fetal monitoring does not improve outcomes. They recommend intermittent monitoring, which is what we use at home, and it works very well.
Okay, so why do families choose home birth over a hospital birth?
A couple of main reasons tend to come up a lot. Some choose it because they've previously had a hospital birth, they had a really bad experience, and just do not want to repeat a negative experience. And some are just really very much looking for a more natural approach. They don't want to have unnecessary interventions that, while you have a right to refuse them, sometimes it can be difficult to do in a hospital setting, such as IV fluids or being stuck in the bed with continuous monitoring, things like that. They get a lot, and some families want it for options that we can do at home that they might not be able to find in the hospital, such as a water birth.
Okay. So how does it look different? To someone who's only, well, maybe let's say it's a woman who's kind of considering, where she's going to birth with her first baby. How does a home birth look different and feel different than a hospital birth?
We really work to make the birth space not feel medical. We have all our equipment ready in case we need it, but we try and kind of keep it tucked out of the way, kind of discreet. So you really maintain that feel of, I'm in my home, I'm in my comfort zone. It's a safe space. Candles are common, low lights, music, and really just following whatever the family wants. If you want to eat, if you want to drink, we're accommodating to any of those wishes.
Okay, so how come you can't do those things in a hospital if they're so safe and there's nothing wrong with them?
Some hospitals are starting to move in that direction, but ultimately they find like, oh, low lights are difficult because we can't see what we're doing, or candles they usually don't allow because they consider it a fire hazard. Water birth, some hospitals allow it, but a lot of times what you'll find is they might let you get in under certain circumstances, but their parameters are very narrow for when they will allow a woman to get in the water. Like, she can't have her her waters broken if she wants to get in the tub, or she has to constantly get out to check the baby's heart rate because they might not have a waterproof Doppler, or they frequently don't allow eating and drinking in labor because they're concerned that if they go for a surgery that she might vomit and aspirate.
Okay. There's like a million follow-up questions I have to all those, but I'll try to stay on target. So I kind of want to talk a little bit about just the history, so playing devil's advocate a little bit. Before we moved birth to hospital, didn't babies die all the time? Isn't birth really dangerous?
Birth always has some potential risks. That is absolutely true. But with a lot of advances, midwifery has also advanced. So the same things that made hospital birth somewhat safer, we've also been able to bring that into the homes too, such as being able to monitor babies with a Doppler and having the medications available in case there's excessive bleeding. Emergency transportation is a wonderful option as well. So if there is an emergency at home that is, outside the scope of managing it at home, we can transport to a hospital quickly and reliably.
Okay, so let's talk about what some of those circumstances might be. When would you transport a woman? And I think the biggest fear that a lot of people have why they think home birth is just not an option at all is, how do you know you're going to have time? I mean, don't these things happen really quickly? Isn't time essential?
Right. So one of the things that makes it a little bit different is you're always receiving at least one-on-one care. Typically, there are 2 midwives to every laboring woman, so it's actually sometimes 2-on-1 care. And we're constantly monitoring both the mom and the baby. And instead of just looking at their vital signs, we're also looking for more subtle signs that things aren't going well. So we can detect an emergency maybe sooner than they might in the hospital, where it's maybe a few nurses looking after maybe a dozen laboring women. And they've got many different duties, and it's divided, and it might take a little bit longer. Additionally, once we identify that there is a problem and we need to transport, we call ahead to the hospital, to the labor and delivery, and we let them know what's going on and that we're on our way in, and they're already prepared for us when we get there. So in the worst case scenario, if we're going in saying we know we're going to need a C-section, they can be preparing for that ahead of time. And oftentimes there is not really a significant delay, because even if you're in the hospital, it usually takes them about half an hour to prepare even for an emergency cesarean. So instead of just waiting in the hospital labor and delivery room, we're transporting there, and not a significant time is lost as long as you're not really far away from a hospital.
Well, and I think that's a great point that, when you're birthing at home, you have 2 midwives who are just watching you and your signs, and they're observing you. Whereas in a hospital, it's the nurses, not your OB, or even if there's nurse midwives, they might not be there actually in the room with you very often. And they rely a lot more on, that's why they like the continuous monitors, because they can monitor baby's heart rate from the nurse's station and handle a lot more patients. And that's, I think that's a very different experience for the mother. And it's also a very different way of observing. So tell me a little bit more, what are some of the signs that you're, the more subtle signs that you spoke about? So obviously everybody watches baby's heart tones. Mm-hmm. What are the other things that you're looking for in mom that might signal that things aren't going so well? You might want to start considering a transport.
One of the really subtle ones that really plays in well with having developed this relationship through the course of prenatal care, where you're always seeing the same providers, is we really develop a good sense of what is normal for this mother. And we really listen to her gut instincts. Women have great intuition, and there are a lot of times where outwardly everything looks fine. Maybe the baby's heart rate is fine, her vitals are fine, everything's stable, but she might just have this sense of, you know what, I just feel like something's not right. It doesn't happen frequently, but it does happen every once in a while, and we'll say, okay, well then let's act on this. And sometimes they feel that before anything shows up, and then maybe by the time we get to the hospital, a baby's starting to show a little bit of signs of distress. So those are some of the subtle signs that we wouldn't notice if we weren't constantly in contact and having that really great open communication where we're respecting their intuition and what they're feeling is going on with their body.
Mm-hmm. Well, and I would say that's probably another huge difference with an out-of-hospital birth experience is that, you rely on mom a lot more. Mom's really more at the center of it. And I think, not always, but very often in the hospital setting, she can get a little sidelined, and that's a really different experience for her to have.
Absolutely. A lot of times the focus is on baby. Let's get baby here. How's baby doing? And mom's kind of like, oh, let's check her vitals, but she kind of gets lost in the equation far too often.
Yeah. Okay, so what were the biggest risks? Why did babies die, 100 years ago before we had births in the hospital? What were the most common issues?
One of them was simply sanitation. They did not understand how germs spread. And so, especially even when physicians were attending home births, they would go from one to another, and sometimes with midwives, but less frequently because they didn't attend births as frequently. They would not wash their hands, they wouldn't wear gloves, and so they were spreading germs from one to another. So a large cause of death among the women was what they called childbed fever, and they were just spreading infections between the different laboring women. As far as the babies go, they did not have resuscitation equipment. They didn't have great options for monitoring. Is this baby too young? Is this baby a preterm baby, which has separate risks? Infections for the baby, and also vitamin K. They did not have vitamin K supplementation, nor did they have great sources of vitamin K in their diet. And so now that was a huge cause of death in babies that now we can head off with supplementation in the mother's diet, the baby's diet, or with the injectable form, whichever the parents decide.
What does vitamin K do?
Vitamin K helps the blood clot. So all babies are born with insufficient levels of vitamin K, and most of our vitamin K comes from our bacteria in our intestines producing vitamin K for us. And until babies develop that great amount of bacteria in their guts, they just can't make enough, and that can take up to a few weeks. So for many babies, they're okay, but if a baby has a traumatic birth, or especially if there's another factor that makes them prone to bleeding, then they could have insufficient amounts, and without that extra vitamin K to help them out, they could have bleeding either internally or externally.
Okay, and what do you do in a case of hemorrhage? I think that was another problem that,
Absolutely.
years ago they weren't able to handle as well. And how are you able to handle it out of a hospital if it occurs?
So hemorrhage is actually one of the complications that people are most concerned with, and it is one of the ones we see the most frequently. It is also usually one of the ones that's easiest to manage. With Pitocin, Cytotec, and Methogen at our disposal, it's usually incredibly easy and fast to get under control. We're always very carefully monitoring after baby delivers for signs of excess bleeding, and we're checking, to make sure the uterus is contracting down properly and that bleeding isn't excessive. And if we need to, we will use the medications, which all have different nuances for the situations where they work best. Most commonly, we use Pitocin, and that just helps to contract the uterus down better to help stop that bleeding.
Okay, and what do we know about, what kind of data do we have on the safety of home birth as it's practiced now? Like, how are the outcomes compared to hospital births, and do we have good data on that?
And one of the things we come across a lot is especially if physicians will say, oh, look at these studies. So many babies die at home. It's very dangerous. Usually the studies they're referencing were including home births that were not planned home births, that they were at home and baby was maybe preterm or whatever happened and came very quickly before they had the chance to get to the hospital, or they were home births that were not attended by a professional midwife. When you look at studies where they are specifically attended by a professional, well-trained midwife, and they are a low-risk woman, then the outcomes are very comparable to hospitals with fewer interventions. The cesarean rates are dramatically lower, the rates of tears are lower, and overall most of the complications are much lower risk at home because we're not intervening unnecessarily.
Okay. What kind of interventions do you do? Do you ever do episiotomies?
We have the tools for an episiotomy, but it's incredibly rare need. I've never done one. The midwife I work with has never done one. Most of the time, by the time you get the baby down to that point where you would perform an episiotomy, the issue is not the soft tissues if the baby is getting stuck, and creating that extra space is not going to solve the problem. The only times I've seen an episiotomy done where it was helpful was actually in a hospital birth where they were using a vacuum and they needed the space to be able to place the vacuum on the baby's head.
So how many hospital births have you seen?
Probably about 5.
And how did it feel to you watching a hospital birth?
It's very surreal. Most of them were transfers from home. One was like a preterm baby. And the one that we prefer, this hospital we prefer in New Mexico, is really accommodating. They're a wonderful choice. They're very respectful of the fact that these women had chosen a home birth and they weren't able to do it, but they're not demeaning to the women for their choices. Sometimes they get met with a lot of hostility. So for the most part, they've been good experiences.
Okay, and let's just talk about, what do you know about other countries and home birth?
As far as a lot of European countries, they usually have a lot more home births, and their midwives have a great setup where they can, if they have to transport from home, they can go into the hospital and still be the primary care providers for their clients, which is different than in the US. We don't have that setup, and it really is unfortunate. At the very least, that we don't have a better system in place for transporting, even if we don't maintain our position as the care providers, just that there's not a good system for relaying healthcare and working as a team for this client.
Well, it seems like, I mean, I think in most European countries, and probably outside of Europe as well, I just don't know, but the midwifery model is the standard. Women see midwives unless they are higher risk. So
Yeah.
like the midwife she's treated as, more of a peer, like a medical professional. Like I know in Holland, they have a lot of midwives. And from what I understand in Britain now, correct me if I'm wrong, but I think they now recommend that home birth what do they recommend home birth
Right,
for women
as
who
an
are
option for all low-risk women. Yeah, that they should all consider it.
right. Okay, so when does someone risk out? When a woman comes to you and says, I want a home birth, and what are you looking at to be able to take her as a client? What makes her low risk, and what conditions would you then refer her and say, no, you need to be seen by an obstetrician?
Some of it is state dependent. We have our guidelines by the state. For example, in Texas, twins and breeches and vaginal birth after multiple cesareans is allowed in Texas, but it's not in New Mexico. But generally, we're looking for high blood pressure increases your risks, and you should probably be seeing an obstetrician. Uncontrolled gestational diabetes, hyperthyroidism, conditions like that place additional risk on the pregnancy, the birth itself, and for the baby. we generally would recommend a hospital birth because they're better equipped to handle those increased risks.
I feel like that's another misconception that I've encountered around this topic, that people think that, if you see, a home birth midwife and they just want you to birth at home no matter what, and that they're willing to take on, higher risks, and that they're, I don't know. I think people don't understand that, they don't want to take women who are at risk of serious complications.
Right. And there may be midwives who feel that way, but most, like all the midwives that I've spoken to, we all agree that you're best off birthing where you feel the safest and most secure, because that's where your body's going to be able to do what it needs to do the best. And so we're here to serve the women who feel like that place for them is at home, and that their low risk status makes them a good candidate for that as well.
Okay, so last question. Where do you see the future of either home birth or just professional midwifery? What do you see happening in the world of birth in the U.S.?
The trend is definitely the rate of home birth is increasing. It's also kind of making the environment toward midwives somewhat more hostile in some areas, where obstetricians are getting a little bit defensive of what they consider like their territory. But a lot of that seems to stem from misconceptions that a lot of physicians don't understand that we are carrying those medications and we are trained. They have the same misconceptions that we're just showing up and trying to catch a baby and really don't know very much about what we're doing. So there is some of that pushback, but on the flip side, some communities are welcoming home birth and are like, hey, it's a great option for our women who want it, and we're here for you when you need us. Okay. I see it increasing.
Okay, well, wonderful. Celia, thank you so much. I want to say next month I'm going to be talking with David Carter-Plake. He is one of the midwife providers at the Retreat, which is one of our local birth centers here. The topic, unless you tell me otherwise, is going to be informed consent / continuity of care, perhaps / what does the midwifery model mean? So kind of to delve in a little bit more of what we've been talking about today. So Celia, thank you so much for your time. It's always a pleasure. And we'll be back next month.
Thanks.